So coming to treatment, because the readers of simpleandpractical.com are always like, as the name indicates, is practical. So we are interested very much in treatment. Or diagnosis is practical, and then treatment. So what about first line treatment? I can tell you, Dr. Yadin, that if a patient with OCD goes to see any psychiatrist or nurse practitioner today, you can be 100% sure that they will be given medication, not behavior therapy, in 100% of cases.
Right.
So let's talk about the first line treatment, like before we even get to treatment resistance. But like a patient comes in, they've never had treatment, I diagnose the person as OCD, right? Now, how do I decide, should I give them medication? Should I recommend they should get exposure and response prevention, either with me if I feel like I have enough training, or refer them to someone? Or the third option could be like do both, like start them on medication and refer them for behavior therapy. So how do we decide between these three options?
Right. So the expert consensus treatment guidelines that we have for OCD, as we have for many other conditions, right, recommends the following. So most people agree that where possible, a cognitive behavioral therapy, ERP specifically, is the first line to be offered. Now, we'll talk a little bit about practicality in a bit. But in terms of the guidelines, is ERP should be offered first.
Which guideline are we talking about?
The expert consensus treatment guidelines, which were published a little while ago. We could actually put a referral for people who are interested in it.
From which organization? From which organization?
It was sponsored by the OCD Foundation or supported by, but it's with psychiatrists, psychologists, social workers. Okay. I mean, experts in the field. All the prominent names were involved in those decisions, including psychiatrists, which is important because we need to have all people who get to see people with OCD.
So this is interesting. So ERP, we are going to use ERP, guys, for exposure and response prevention.
Exactly.
So ERP should be the first line treatment, ERP alone, if at all possible, and is the exact opposite of what is actually happening, which is that everybody is getting medication.
Right. So here's the thing. So there's kind of a table. So for mild to moderate cases, ERP should be done first, especially in young children and adolescents, However, when somebody is not able to implement the principles of ERP, it is recommended that medication be added. Now, in most cases, practically, ERP is not as available as medication management. So the good news, though, is that in the studies, the original studies that pitted ERP versus medication, they're equally effective. They're equally effective. So medication has been shown to be effective, and ERP has been shown to be effective. And they don't need to be combined unless a person cannot implement ERP.
Okay.
But, however, obviously, most people don't have access to ERP, and we'll talk a little bit later about how we can increase and improve that situation.
Right.
Here's an important thing, though, in terms of medication. Since we know that many people will be getting medication, we've noticed in the studies that we've done with Columbia and with other centers that when we're looking for people who are already on medication and we want to add either an augmentation med or an additional ERP course or whatever, most people are under-medicated for OCD.
Yeah.
So OCD, the medication for OCD, it needs to be, turns out, to be at higher doses, and it takes longer, right?
Yes, absolutely.
To kick in than antidepressant effect, right?
Yes.
And this has been a very, very interesting finding for us, that when people come into the studies, it turns out they need to wait to be upped on their meds to see a therapeutic dose. This is, of course, if they can tolerate it.
Yeah.
Right? In order to see if they've received the maximum benefit that the medication can offer them.
I 100% agree. And, on Simple and Practical, we previously published an article talking about the use of high dose of SSRIs for OCD, and also promoting the idea that a 12-week trial is needed on the medication. So that's a great point, but great for you to emphasize, that the people with actually, maybe I just want to briefly mention even antipsychotic augmentation. I found that, and I wrote an article about this, that it is a myth that in OCD we should use low doses. So people will use like a really low doses of antipsychotic for augmentation, while that's not what the clinical trials do. And so even the antipsychotic augmentation tends to be underdosed. So,
Right.
so yeah.
First, I mean, obviously, you will first sort of
Yeah,
maximize the dose of the SSRI, so we don't
correct.
need more augmentation
Yes,
if necessary, right? Exactly.
yes.
So we all need to give the dose that is effective, and we definitely understand that people are going to more likely have access to to the medication. The one other thing that is important, of course, and it's important to tell people this, is that we don't know yet how long somebody needs to be on medication before they can start tapering it off. There's a study that will be coming to publication soon about what that would be. But we also know just from the research that ERP, of course, has more long-lasting effects because it's not when discontinuing. Truly, people do not discontinue ERP because they continue to implement for the rest of their lives. So
Yeah.
really the maintenance of the gains is better with the ERP. And this
You
is
know,
why education needs to be just one step, and teaching people the principles of ERP would be wonderful.
that's a very, very important point that you made. I want to emphasize that the ERP is to a great extent a permanent treatment. Doesn't have any firstly, no side effects, like because there's huge complaints about side effects with SSRIs for OCD. Uh, and they may require some booster treatment maybe in ERP, but in a
Right.
general sense, it's a permanent treatment. And this is very important to keep in mind when thinking about cost, because
Exactly.
maybe it's a little more costly right now because you have to go every week or
Upfront.
twice a week. But if you think long term, then I don't think ERP is more costly than medication treatment.
And we've even done sort of informally, we've looked at it in terms of insurance. For insurance companies, they also pay much more over the long run when somebody is medicated for a long time and needs to visit a psychiatrist every few months to make sure
Yeah,
that the side effects and all that, yeah, versus the cost. So it's a short-term big investment for long-term benefit.
yeah, right.
And as humans, we're not good at that. We're not good at seeing that it's a really good investment upfront for long term. We're humans. We see it in here and now. So it's
Absolutely.
understandable why people are looking at it differently.
Yeah. One question, in terms of, you said ERP as first choice. If if it's more severe, we may consider starting medication and ERP at the same time. One
Correct.
problem though with starting both at the same time, I try to avoid that whenever possible in my practice, is that you don't know what worked. And we know that OCD is a chronic, relapsing, and remitting condition. It on its
Right.
own, it tends to vary in severity over time, and it would be really good to have confidence that the ERP worked without medication, because then the person will be motivated to keep doing it.
Right. I mean, so you can do start with a medication and then, if needed, augment with ERP. Most people who work in OCD, psychiatrists and psychologists, but psychiatrists also with whom I collaborate, will agree to do the medication on one condition, is that the client eventually does ERP as well.
Right. Right.
Because
Oh,
we know that we want to get young people off of their meds if we can, and have something that's long lasting. So
so now, what about, is there any reason to believe that medication can interfere with the effect of ERP? Because I know that, for example, benzodiazepines, certainly behavior therapists don't like benzodiazepines because the benefits of behavior therapy decrease. Is there any such concern in case of OCD?
the good news is SSRIs or SNRIs, something that is a chronic process, that the therapeutic effect is chronic, like an SSRI and SNRI, does not interfere with the treatment at all. The reason benzos sometimes interfere, especially if they taken as needed, is that clients use them like a compulsion. So they do it as a way to not feel the anxiety or the distress. And so in that respect, the whole point of ERP, which is distress tolerance, and you don't need to do anything right now to make the distress go away, just allow it to naturally go away, is interfered with. And so the learning is interfered with, that distress will go down on its own without heroics, basically. It will go away given enough time and tolerance, which is not easy. If you take it down, it's like escaping, it's like avoiding. And so that's why the benzos are a little bit maligned in the OCD world. But
so you would recommend minimizing or avoiding benzos, and in particular and telling patients not to take benzos PRN as needed when they are having more distress while doing ERP. That would be counterproductive. We should really emphasize this point.
Exactly. And we have patients who have, let's say, they take benzos for sleep or something like that. It's not a problem. It's when they try to use it as a compulsion, reduce the distress.